Okay, are the lines open?
Yeah, I think we can start.
Okay, good evening, everybody. Very welcome to this third part of the webinar series on non-invasive ventilation. In cooperation with BREAS. Am I still on? Because I get error message here.
Yeah, you can click send to Zoom.
Okay. So welcome to this third seminar on non-invasive ventilation. We had earlier this week 2 seminars, and this one is now concluding this series. In today's seminar, we have a guest which is invited. The seminar will focus on non-invasive respiratory support and COVID and ARDS. And first of all, in the first half of the session, we have Professor Stefano Nava from Bologna, the north of Italy, which you might know has been in the center of the COVID outbreak in Europe, and has been one of the parts of Europe which was hit hardest by COVID. So we're very thankful that Professor Nava is willing to share his experience while of him and his colleagues being in the eye of the storm, and what lessons they have learned in relation to non-invasive respiratory support for COVID and during the treatment of COVID. Before handing it over to Professor Nava, I want to draw your attention on a website we're hosting, which is called Education by BREAS, which is an educational platform which we have launched, where you will be able to find videos, interviews with key opinion leaders, as well as product tutorials, but also white papers and abstracts of important literature around ventilation, airway clearance, and monitoring. A platform which you can easily reach by educationbybreas.com, which you can consult, of course, on your computer as well as on your tablet or mobile phone. So after this, and for future follow-up and news on the highlights of respiratory care, I invite everybody of you to visit us and maybe even register on educationbybreas.com and get the latest insights in novelties in respiratory care. That being said, I would like to hand it over to Professor Nava for his lecture on non-invasive respiratory support during the COVID outbreak in the north of Italy. Professor Nava.
Okay, thank you very much, Carl. Thank you very much, organizer. Thank you very much, BREAS, for the kind invitation. Can you see my first slide?
Yes, visible, sir. You can proceed.
Okay, thank you. These are my conflict of interest. Please, if there is some problems with communication, let me know. Okay, so, wow. I want to start since the beginning. On February 21st this year, I was skiing. Carl Van Looy knows exactly where I used to ski, and I received a phone call from our former fellow, Francesco Tursi, that lives in Lodi. Francesco is the guy that you can see in the right-hand side, and Lodi is a relatively small city with an hospital of 400 beds. So early in the morning, he called me and he said, "Hi there, here is apocalypse now. We admitted tonight 51 patients with acute respiratory failure. After 1 hour, our 8 ICU beds were already full. We implemented very rapidly our respiratory intensive care unit with 2 additional beds for a total of 7. Now we got 15 intubated patients on the floor, and they are connected to home care ventilator or even ambu bed. People are falling down on the emergency room floor. Next to the hospital, where I was used to live when I was a kid, is even worse, I was told. That was a real life situation. The first day when we were hit by the outbreak, the first probably European nation. On March 19, the situation was so bad that the cemetery didn't have any more space for people who were dying. This is a picture taken from an online newspaper and describes army convoy takes Bergamo coffins out of Lombardy just to be buried in other place in Italy. So the situation was extremely bad, I would say dramatic. So let's go to the real life. Here is the European situation about the number of ICU beds per 100,000 people. As you can see, there is a large discrepancy between some countries like Germany and Luxembourg, where the number of ICU beds per 100,000 people is around 30. In Italy, we are just in the middle, 12.5. And other reality, like Greece, Sweden, and Portugal, were really, really bad located, because as you can see, you have a very small number of ICU beds. Well, this needs to be taken into consideration when we talk about pandemics. And pandemics, as you know, means several times acute respiratory failure. Well, very briefly, in the first part of my talk, I'm going to deal with invasive ventilation and COVID-19 infection, because it is extremely important not only to speak about non-invasive respiratory support, but also the other side of the coin, invasive ventilatory support. Well, this is a quite recent study. The title is very appealing: ICU outcomes of COVID-19 critically ill patient, an international comparative study. Well, the first thing I want to mention is the word ICU. This data refer to ICU. And as you can see here, in Europe, I would say 90% of the patients, even more, were directly intubated in the ICU. In North America, this percentage dropped to 80%, more or less as in Iran, while in China, the proportion of patients admitted to the ICU required directly intubation was much lower than 50%. But it's not only important to understand what was the proportion of ICU patients requiring intubation, but the mortality rate. Well, this recent study, by what Bailey, a systematic review and meta-analysis of observational study, dramatically posed to us the problem of mortality. Why do I say dramatically? Because you see here the dot line is placed on 40% mortality rate. And you can see that especially in the early days in North America and in Europe, the mortality rate was extremely high, overpassing 60%. Well, these are data that shocked me really when I saw them. There are some studies, like the one performed in New York City by Richardson and al. On 300 patients, more than 300 patients, they observe an 83% mortality rate in invasively ventilated patients. Well, this meta-analysis obviously has some problems that were highlighted on the left-hand side, because the primary outcome measure was death in intensive care as a proportion of completed ICU admission. either through discharge from the ICU or death. The definition, therefore, did not include patients still alive on the ICU, and this way maybe overestimate the problem of mortality. Nevertheless, this data, as I said once, is really shocking. We always taking as reference for good healthcare system Germany. Well, this is a recent paper published in the Lancet on more than 10,000 patients admitted to more than 900 Germany hospitals. And you can see here, Germany did exactly as the other European country and North American country did. Look at here the mortality of patients requiring ventilation. As you can see in the right-hand side, only less than 10% of the patients require non-invasive ventilation. 90% of the patients require endotracheal intubation. Well, the mortality rate in, let's say, in the age frame between 60 and more than 80 was overpassing once more 50%, even in Germany. And it was extremely high, 73% in older patients. That means over 80 years old. But even in the age range between 70 and 79, the percentage of patients who died was really high, 63%. And you need to consider that in general, the German population is much younger than the rest of Europe. Well, the title of this talk is Our Experience in Our Own Country. March 8th, these are what we expected by this epidemiological curve in a paper published on Lancet by Andrea Remuzzi. Actually, what is suggested is that by March 14, so 2.5 weeks after the outbreak, the number of Italian ICU beds would be overwhelmed. Well, this poses another problem. Where are we going, or where are we going to admit those patients with acute respiratory failure when ICU beds run out? This happened all over the world, I think. I guess it's the same in India. It was the same in the US. In this JAMA paper, out of 355 hospital admissions for COVID-19 infection, only 69% of the patients need to be admitted to the ICU. But later on, 72 of the 286 patients admitted to the general practice unit, they needed to be transferred to the ICU. And once more, the question is, and if you run out of ICU beds, you know that in the States and in Germany, they have a lot of ICU beds. But as I show you in a previous slide, in most of the European countries, we really are at shortage of ICU beds. Let's make this real life example. These are data taken by the North Italian Registry from February 21st up to March 18th. Only in a region that is Lombardia, that serves 9 million inhabitants, 1,600 patients in 3 weeks occupied all the ICU beds in that area. But as you figure out, almost 9,000 patients need hospital admission. Roughly 3,000 of them in 3 weeks with acute respiratory failure. So if you make a simple calculation, 3,000 patients with acute respiratory failures minus 1,600 that could find a space in the ICU means that 1,400 patients with acute respiratory failure could not be admitted to the ICU and need to be treated outside. Well, very early, we published this, I would say, consensus guidelines. They were not, I tell you, all evidence-based, because we really ran out of time. We need to do very quickly. And this was an early consensus management for non-ICU acute respiratory failure. Well, I don't want to go into details in this flowchart. It's boring, probably. Just to show you that very early, we faced the problem where to treat the patient with acute respiratory failure when ICU beds were fully occupied. Rough number, more or less. This, as I said, a rough number because they were very difficult to collect in all over North Italy at that point in time. So about 11% of the patients with acute respiratory failure underwent only standard oxygen, 18% Venturi or reservoir mask, about 19% high-flow nasal cannula and NIV, and the large majority, 32%, underwent a trial with CPAP. We come back later on why CPAP and not other kind of non-invasive ventilatory support. Well, this is, I put 3 studies already published on the use of CPAP. The first point I want to make is that we always use helmet CPAP, whatever you want to call it, helmet or hood, is the thing that you put on your face, on your head more than face. Well, it is interesting to note that the consensus decided to perform CPAP with the helmet for 2 simple reasons. The first one, because we thought at that point in time that helmet was the safest way to apply an aerosol generating device. The second, it was easy of use and lack of ventilators, because we received, as I told you, so many patients, and we very early ran out of real ventilator, either home care, NIV platform, of ICU ventilators. So just to say that we need to decide this not because we thought the CPAP was better than the other techniques, but just because we really need to apply something that it was very simple also from the nurse's standpoint and for the non-specialist standpoint. We need to enroll on board pediatrician. We need to enroll on board neurologist, laryngologist, surgeon. So you need something extremely simple. So in this first study that I show you, only, I would say, 21% of the patients were intubated using CPAP and 22 died during the pandemics in this relatively small sample of patients, 150. Well, I know that it's very difficult to perform a randomized control trial because of ethical committee, because of pandemic sick use so fast. But there is another study using CPAP that tried to get a control group. And I thought it was interesting. This is a paper out of France. And what they did, they compared the first 2 weeks of pandemics, period 1, blue line, where they did not have still access of CPAP. And the second 2 weeks period, orange line, in which they started using CPAP. And you can see here, when you start using CPAP, you could avoid, and this was statistically significant, the occurrence of endotracheal intubation. This is the study, I think, most important, not just because we did it, but just because it's the largest one. I'm gonna show you in details this study. We enrolled 670 patients, but here I want only to focus on the CPAP problem, because we are talking here about CPAP. Once more with the helmet. And we observe out of 330 patients treated with helmet CPAP an intubation rate of 25%. And if you compare the endotracheal intubation among the 3 studies that I show you, there is always a very consistent percentage of patients requiring intubation, between 20 and 25%. But one may say, well, these are not sick patients. You show us before data on intubated patients, and obviously we may think that intubated patients are sicker. Well, it's true, probably, but I just want to show you what was the PF ratio in this patient. 151 in our study, 149 in the Aliberti study. The Orange study did not report a real PF ratio. So just to say that this patient was not dramatically sick, but they were very sick. And still they could be quite successfully managed. Well, but the title of this talk is not only CPAP. It's related to non-invasive respiratory support. This paper is already online on the ERJ website, and refer to 670 patients treated in 9 Italian hospitals located in north center of Italy in the time frame between March and May. Obviously, it was a retrospective study based on prospective data collection. Just to clarify the issue, where did we treat this patient outside the ICU? Well, in 2 different units, usually. The first one was a simple monitoring unit. That was a former respiratory ward with a dedicated respiratory monitor consisting of specialized monitor area and with an active full-day shift run with pulmonologists and a reinforced nurse-patient ratio between 1:4 and 1:6, depending on the hospital. And the second of a classical respiratory intermediate care units that usually is more sophisticated because you may have access of ICU ventilator, a little bit more sophisticated monitoring, and 1 out of 3 usually patient to nurse ratio. This just to give you a perspective of what we're talking about. Well, at the end of the day, as you can see here, we treat, as I said, 670 patients, 24% using high flow nasal cannula, 49% the helmet CPAP, and 25% with non-invasive ventilation. Once more, I want to show you the PF ratio. The mean PF ratio was 152. And clearly, a patient undergoing a high flow nasal cannula trial, they have a higher level of PF compared to the helmet CPAP, but especially with non-invasive ventilation. So with non-invasive ventilation, we treat sicker patients. Just to get you an idea, the large Italian study that I referred at the beginning on 1,600 patients in the ICU reported data on patients with a PF ratio 160. So in this study, we treated even at least concerning the PF ratio, even sicker patients. Well, these are the main outcome of the study. That is the 30 days mortality in the endotracheal intubation. Well, when you see the crude mortality, you may see that, for example, the high flow nasal cannula was associated with a reduced risk of death. But when you adjust for severity of the patient based on age, sex, PF ratio, comorbidity, etc., this difference obviously disappear. And therefore, all the 3 devices got more or less the same mortality rate. This holds also not only for mortality, but also for endotracheal intubation, length of ICU and hospital stay. So all the three different devices, despite they were applied with different level of severity, resulted in similar mortality when all these variables were adjusted. Well, give us some more information on these 670 patients. So we try to better understand how mortality was associated. Well, it's ended up, as you can see here from this busy slide, but please look at only at the bottom, that mortality obviously increased with age. This is not surprising. We also saw the data from the German groups, and increase when you got more than 2 comorbidities. And this was statistically significant. Conversely, it's not a contradiction. Endotracheal intubation was higher in younger patients and with less than 2 comorbidities. Younger, less comorbidity, but just because we need to decide at one point in time which guy merit intubation and which individuals did not merit intubation. Because as I said, we ran out of ventilators, we ran out of ICU beds. So it was clearly driven by the age and by the amount of comorbidity, the intubation rate. However, this was not statistically significant. What about the PF ratio and mortality? Well, not surprisingly, when PF was very low, lower than 50, mortality rate was very high, 45%, but still less than was reported in the ICU. And within a range of, I would say, moderate, severe to moderate, hypoxia, the intubation rate was lower than 25%. So I'm very pleased to present this data because this means that you can really got nice data of sick patient even outside the ICU. Well, I think that was not only matter of non-invasive respiratory device, but was also matter of what we learned with time. And one of the things we learned was the effect of prone positioning in patient non-intubated. This is a Lancet paper by the Monza group, and they show that awake prone position is feasible and improve oxygenation in patients with COVID-19. So I'm going to show you some real life data just to share with you what was our early experience. 74 years old woman was admitted to the hospital after 10 days of fever. She has some comorbidities. She tested positive on March 20. It was funny because on March 20, I tested positive too, exactly the same day I got sick with COVID. And this lady was transferred 3 days later on our respiratory intensive care unit. Well, she did not, she was a sort of a typical patient with COVID. Why is it typical? Because she was hemodynamically stable, almost normal respiratory rate, normal sensorial, but very bad arterial blood gases. On reservoir oxygen mask, her PF ratio was lower than 90. Well, so she received all the therapy that were according to our internal protocol, hydroxychloroquine, antibiotic therapy, tocilizumab, and so forth. But obviously, we need to think something different. This is the CT scan of the lady, bilateral consolidation with ground glass area, mainly in the posterior dependent zone or areas, whatever you want to call. Well, we decide to start an NIV, and once more we use a ventilator. I suggest you to ventilate the patient with a monocircuit, but with a specific filter or double circuit, and with the helmet. Once more to minimize contamination. The pressure control to better control synchrony, especially with the helmet, the setting, pressure support 24, PIP 12, inspiratory time 1, 80% of FiO2 with a very fast pressurization rate. This because has been suggested by a few studies that with the helmet, you should use this kind of settings. Well, 2 hours after, the picture did not change. We were very disappointed. PF ratio did not improve from actual proof from 89 to 92. So nothing really happened. And the patient was also not very happy probably because she felt that she was not improving, was not also very happy with NIV. So we did something. And you can clearly see here what happened to saturation. Saturation is the yellow line. You see baseline saturation, then boom, something happened, and then we stopped what we were doing. 1 hour later, you see here the time is marked. What happened here? We kept exactly the same respiratory parameter on the ventilator, but we only prone for 1.5 hour rotation. And right away, as you can see here, right away, vertebral gases ameliorate significantly. Watch PF was 83 and went up to 103. And this periodically proning the patient was associated, even during non-invasive ventilation, with a much better gas exchange. Well, I want to finish the last 5 minutes to a thing that I really concerned. Because when I talk about non-invasive ventilatory support, especially in North America, all the people are saying, well, stop it. This is too dangerous for the staff to apply. As a matter of fact, if you go into details and you try to see what the major international society are saying about the use of non-invasive respiratory support during pandemics, well, there is a sort of discrepancy. Red light means some society are totally against. Green, some society are, I would say, I don't say in favor, but they're allowed to do it. And this paper is already online on CHEST if you want to see it. Well, we were very concerned, especially at the beginning. And most of the data, if not all of them, but I'm going to show you, are coming from this paper by very young fellow. She's 26 years old, is Martina Ferrioli working with me. She did a terrific job going back to all the paper published so far and putting together this document that after 1.5 months, I have already almost 100 citations. I mean, I was really surprised. Never happened to me to have 100 citations in a paper coming out 2 months before. When we talk about non-invasive respiratory support, we are talking about droplet. Droplet means respiratory aerosol with a diameter higher than 5 millimicron, okay? So we need to take into consideration that this particle may remain suspended in the air for a variable amount of time. Well, the World Health Organization stated that this patient, when you apply an aerosol device, whatever it is, from aerosol therapy to NIV, patients should be placed in isolation room with a negative pressure with at least 12 hours change per hour, dedicated bathroom and possible an anteroom. Well, but this is not taking into consideration an emergency situation like pandemics. We ran out of negative pressure room after 24 hours. We only had 18 in all the hospital. Our hospital has 1,260 beds. So the first night, boom, we ran out of negative pressure room. So what should we do? ICU bed were totally occupied. Negative pressure room, totally occupied. We should see the patient die. So if you go into the document of a WHO, there is a very interesting statement. If negative pressure rooms are not available, choose rooms with natural ventilation with airflow of at least 160 liters per second per patient. So here, I apologize, this is Italian, but this is real life. This is our unit. This is not the intensive care. This is a regular work. And we, with the help of the engineer, we calculate according to the wind, how should the door open, how should the window open, how high was the ceiling, how large was the room. They calculate the amount of liter per second. And as you can see from this slide, despite it's in Italian, in each rooms, we could get a satisfactory airflow, but it was at least 2 times more the suggested 160 liters per second. So just to say that even the WHO allowed you to perform aerosol generating device, provide you have a sort of decent airflow. Remember, and then the airflow generating procedure are not devil. This is a study performed mainly in Taiwan and China, and during NIV with a full face mask, IPAP of 10, EPAP of 5, single circuit, the droplet may reach 60 centimeters. If we increase the IPAP to 18, less than 1 meter. That is exactly the same if you apply oxygen. So what you should do, you should not even provide oxygen to the patient because 4 liters per minute, they already reach 60 centimeters. Why did we use the helmet? Because it has been shown that when you apply NIV with the helmet, in this case, the IPAP was 12 and 10, the droplets reach only 17 centimeters. And if you increase the IPAP to 20, the maximum distance that the droplet may reach is 27 centimeters. So it's not as bad as it was described, this problem of aerosol. And if you use high-flow nasal cannula, the Chinese told us that it's very simple to avoid massive spread, putting on the face of the patient a simple surgical or medical mask. Well, let's go back to the guidelines. Well, the ERS ATS guidelines did not make any recommendation about the use of NIV during pandemics. And I perfectly understand. I was the senior author of this paper, but at that point in time, we didn't have data. And right now, we do not have a randomized control trial. But honestly, how can you perform a randomized control trial in this situation? I think that almost 700 patients, plus the other in the study that I show you, clearly show you that these devices are feasible, but still we have a problem of safety. Well, first of all, you need to protect yourself. You know how to protect yourself with shields, with the glasses, with the suit, but you also need to understand that, for example, the vented mask should be avoided, obviously. You should put filter to avoid spread. You should use sometimes the double link circuit ventilator, so you know what to deal with. Very recently, it has been suggested that if you use a constant flow canopy system, you may protect even better the staff from the pandemic's contamination. I never tried this, but I think the idea is interesting. I don't know how much noise is this, because from this picture, the box, the vacuum cleaner looks very big. So I don't know exactly if it's worthwhile or not. As I told you, I got sick also COVID-19. It was a very tough period for me, but it was much worse from most of the Italian physicians. We wrote this editorial because 169 Italian doctors dying during COVID pandemics. But coming back from our study, we also calculate the number of staff who got positive. Well, out of 370 workers, 42 tested positive, 11%, 9 shown mild symptoms, and only 3 needed hospital admission. And you may say, well, 11% is a huge percentage. Maybe, but look at what has been recently published. Prevalence of SARS-CoV-2 antibodies in healthcare personnel in New York City area. These staff workers were not, or most of them were not directly involved in providing non-invasive respiratory support. And they have a higher percentage level of exposure to COVID-19. So we got 11%, they have 14%. And most of them did not use NIV, high flow nasal cannula, or CPAP. Well, coming back for the Italian sacrifice, just to show you that only 2.5% of the doctors who died in our country because of COVID were pulmonologists. The large majority were general practitioners, dentistry, even cardiology and surgery. But very, very few pulmonologists, suggesting that if you know how to protect yourself, if you know which caution you need to take in applying non-invasive respiratory support, you may avoid major infection due to COVID-19. Well, this is my hometown hospital. I told you that I lived when I was a kid in this small town, small hospital, but was the second city or town hit by these pandemics. And 2 days after the pandemics occurred, this banner was hanged outside the hospital. And it reads, Medici, infermieri, siete il nostro orgoglio, grazie. That means doctor and nurses, you are our pride, thank you. This COVID-19 taught us a lot of things. But one thing also, I would say, was very helpful for us as staff to get closer with our patients, with our relatives, with the general population. And this is my last slide. I want to dedicate this talk to the 169 doctors and 34 nurses that died of COVID-19 in Italy, in particular to one person. The person is the one in the middle on the right-hand side. He's called Giuseppe Lanati. He was a good friend of mine, a pulmonologist, common, and he died on duty. He was already retired, and he came back to work just to help all the others to deal with COVID infection. And unfortunately, he died. And Giuseppe, this talk is really dedicated to you and to all the other 168 doctors and nurses who died. Thank you very much, and I would be eventually very pleased to answer to your question, if I may.
Thank you very much, Stefano. Thank you for an excellent presentation. I think it was really showing real-life experience, as one can only live it when they are really on the front line, working daily with the patients. I think there are a few questions on the chat.
So it's better if I stop sharing and I go to, yes, I think it's better. Okay.
Yes, that works out fine too.
Question.
So while weaning the patients from high flow nasal cannula, what should we decrease first, the flow or the FiO2?
Well, I think that since these patients are mainly hypoxic, my gut feeling is start with FiO2. But you need also to consider one thing, that this patient, they may be very dyspneic or not. So it depends also how high is the drive, because the higher is the flow, the less work of breathing is the patient doing. So I have no clear answer to give you. However, I would say, well, this is hypoxia. We don't get CO2 accumulation. So the washout of CO2 is not a problem here. It's oxygenation. So I will start with reducing FiO2, but I will also look dyspnea, because if the patient is very much dyspnoic, then also the flow should be kept relatively high. And not all the patients, they can stand a flow of 60 or 80 liters per minute. Some patients, they could not stand, so you need to go down to 40, 35. So this is matter of art more than science. So I'm sorry, but I cannot give you a real recipe, but just use your common sense, that I think is much better.
To stay on the topic of high flow nasal cannula, there is a question on how much flow is needed to deliver 100% of FiO2.
Okay, usually depend. I don't want to enter into details, because then we talk about different devices, you know. So you know that you have 2 or 3 devices, so I don't want to sponsor one or the other. I only say that if you want to provide very high FiO2, sometimes you need to decrease the flow, depending on the machine you are using. Certain machine, you have to reduce less, other a little bit more. But you can easily find out. But usually you should, to keep a very high FiO2, you should decrease a little bit the flow on average.
Okay, another interesting question, I think, was in your experience and in your practice, what was the acceptable oxygen saturation or the oxygen saturation you were aiming for with your patients on ventilator? I assume, well, maybe the same for invasive and non-invasive, or maybe there was a difference.
No, I mean, more or less was, I mean, we target between, let's say, we were happy, oxygen saturation was up to 92. We never overpassed 96, because it has been shown that higher saturation is associated with increased mortality. There are a couple of studies showing that. So we aim in the range between 92 and 96. But once more, depend how sick was the patient. It is clear that if a patient comes to the hospital with 90% saturation and still require non-invasive ventilation, I mean, 92 probably is a little bit low. If the patient comes with 75, that it happens, then 90, it's a big success. So the target is between usually 93 and 96, but once more depend on how early is in the treatment and how is the patient doing on average.
Okay, I think that also, sorry, Dr. Anoop.
Yeah, Professor Nava, like I would like to know a few things from your experience. Like whenever you have the shortage of, like the way you were talking, you have a shortage of ventilator, BiPAP, even CPAP. So how you are triaging the patients at that time? Can you just explain your experience in that?
Well, the only thing we did not run out was the CPAP.
Okay.
So I would say 99% of the patients require respiratory support, they got it. I remember one night they called me and they said, well, we ran out of everything, so we prone the patient and so forth. I mean, the big risk, I forgot to tell you, we did not run out of oxygen, but some of the hospitals, they ran out of oxygen. So if you, let's say, if you are in an ideal world, okay, I would first apply NIV for a simple reason, because you do not require very, very high oxygen flow. Then I would apply CPAP for a simple reason, because there are companies, they made the helmet using a venturimeter, so you may reduce the flow needed to inflate and to provide the CPAP. The worst in terms of oxygen consumption is high flow nasal cannula, because if you need 60, you need 60. And I know that some hospitals, like in Bergamo and in Cremona, they need to very quickly build up new oxygen tanks outside the hospital because they were really running out. I was told that Bergamo is a city of 100,000 inhabitants. And one day, the pulmonologist in Bergamo told me, and he told me, you know, we are having now 162 patients on CPAP, plus high flow, NIV, intubated. So for a city of 100,000 inhabitants and 160 only in CPAP, that means that oxygen in the tank was consuming very fast. So you need to consider this. And every day we got a report from our engineer stating at 6 p.m. how was the reserve of the tank in the hospital.
Professor Nava, one more thing, like we are hearing so much about the self-inflicted lung injury because of too much driving pressure in the patients with COVID. So what was your experience and how was you dealing with that situation, especially when the patient was on BiPAP? Now,
we published 2 days ago in the Blue Journal a paper on this. We monitor, not in COVID, we monitor transpulmonary pressure and inspiratory effort in patients undergoing NIV for hypoxic respiratory failure. And we find out, obviously, that more than transpulmonary pressure, it was the esophageal pressure swings that were determining the failure. I think we have, as repeatedly stated by Gattinoni and Marini, there are two types of patients, right? The H and L type. And today we also correct the proof of in Lancet because we try to characterize the patient who die and patient who not die. Just to sum up. So if you have a good compliance, if you have a ground glass patch opacity, if you do not have already consolidation and low compliance, well, I think these devices, non-invasive devices, may work without stressing too much the system. While if you already pass on the other side, well, I think it's useless, and then you may write, I mean, this patient needs to be intubated. The question is, how far should we go with a type A patient for if they do not improve? I think this was a mistake. I mean, I think that because people, they claim sometimes that CPAP sometimes worsen the situation, and probably it's true. But at one point in time, we realized that CPAP was not the best way to deal with that patient, but it was the only option we had. So it was partly our fault, partly was necessity that we had. And the other thing is, in the Lancet paper that you will see before the end of the month, is a combination of low compliance and high D-dimer. So if you have a combination of alveolar damage and vessel damage, then the mortality is huge. If you have one of the two, you can still manage. This is what we learned from the study that we did on almost 360 patients with CT scan and so forth. Marco Ranieri is the first author, and Antonio Pesenti is the last author, but we gain a lot of experience. In other words, in this disease, you need to consider the alveoli and the vessel. And the combination of the two is the worst thing you can have. If you have only one compartment damage, you can still try to, especially if the compliance is not so bad.
Sir, one last question regarding this COVID survivors. So what are the pulmonological complications and non-pulmonological complications you are observing now?
What? I'm sorry, I missed the last part.
the complications, post-COVID syndromes like pulmonary fibrosis and again non-pulmonary complications.
Now, I understand. Sorry. We already follow about 120 patients. It's too bad that I have on mobile phone a CT scan. One guy 2 months ago was on ECMO. He was dead. He came 2 days ago to perform a CT scan. It's normal. So can you conclude that fibrosis is not a problem? No, I say that I saw patients with much less damage when they were admitted to the hospital. They still had some fibrosis on their CT scan. And this guy, I thought he was going to die for sure. I already spoke with the relatives stating, well, very high chance. If you put one on ECMO, you know better than I do that it means that the guy is really sick. And if you see the CT scan, you may say, well, this is impossible. This guy 2 months ago was not on ECMO. I will try to upload if I can. So when you finish, I can eventually send to Carl, and eventually you can show it. But I'm not sure I can manage. But anyhow, just to say how not homogeneous is the response of the patient, but from a patient point of view. I mean, I have a very small ground glass opacity, so nothing compared to ECMO to all the others. My saturation dropped down to 94, not more. But I tell you, for 1 month, my heart rate did not decrease down to 120. And until 2 or 3 weeks ago, I still have a lot of intestinal problems. This is only anecdotal, but just to say that, you know, I got a very mild form and still for almost 3 months, I carry some, I would say mild symptom, but still. So it's a very interesting disease, this one. It's very difficult to say what we're gonna be the long-term outcome.
And Professor Nava, like, what is the current situation there? Are you still getting patients with COVID?
What?
So what is the current situation there regarding the COVID patients?
I don't know. I understand. I'm sorry, but sometimes your voice is fading away. May I touch wood? Okay. So right now, yesterday in Spain, they have 3,700 new cases. Spain is exactly more or less the same population of Italy. Here we got 300 new cases. I don't know. And we are waiting for the second wave, but so far, France, Germany, Spain, I don't know, Carl, about Belgium, but I was told Holland, and especially all the former Eastern European countries, Croatia, Serbia, Romania are doing very bad. So we are kind of isolated. We are balancing so far. I hope we keep like this trend, but I'm not sure. The kids are too stupid. Usually we saw in the hospital only people below 50 years old. And most of them were teenagers like 20, 25 years old. They go to disco at night and I don't know.
And what about the severity in your observation? Is it coming down or the same?
Coming down, yes.
Down.
Very few ICU admission. Like we in our, now, I mean, out of 6 different ICU, from post-surgical, medical, neurological, we got only one ICU that is dedicated, only one dedicated to COVID, 2 patients. One pregnant lady and one old lady with a lot of comorbidities, but 2. And I would say at risk, because pregnancy and comorbidities are risk people, I think.
Professor Nava, another question maybe, because you're mentioning that you are afraid about wave 2. At the very beginning of your presentation, you showed us the flow chart which you had made at the very beginning of wave 1, let's say, in Italy. Would that flow chart, or will that flow chart be different if you make it now in preparation of wave 2?
No, because flow chart remain the same, because severity of the patient remain the same, right? I mean, the virus may decrease the power, I would say, but the severity of the patient is an objective measurement. I mean, if I see a COVID patient with 100 PF, 100 of PF is the same thing now as it was at the end of February. So I don't think we're going to change our flowchart.
Okay, I think for the sake of time, I want to thank you very much, Professor Nava, for this interesting, clarifying, but also somewhat touching, I would say, talk about your personal experience in the COVID outbreak in Italy so far. So thank you very much. And I'd like to hand it over now to Dr. Anoop for part 2 of this webinar. Dr. Anoop.
Thank you. First of all, I'm really happy to share the platform with one of the great physicians like Dr. Stefano Nava. And he has very real experience in dealing many COVID patients as well. Like our experience is just starting. We are just started treating COVID patients now. So he has beautifully explained the statistics and again his experience. So like I'll be just touching upon the things what he has already told. So like some of us may not be aware about the proning, how to optimize NIV, all those things. So I'll be rather sticking on to the theoretical and practical parts without touching much on the literature and the data supporting all the things what I'm going to say. So I'll start with the slide where Dr. Nava stopped. So as we know, there are many indications for non-invasive ventilation. The most accepted indication, as you all know, is hypercapnic COPD exacerbation. As he has already mentioned, there was no recommendation on pandemic viral illnesses because we are not aware or we were not expecting such a huge pandemic as he was already mentioning. But with the experiences from Italy, other European countries, and many other places, obviously there is a strong evidence developing for NIV. The confusion is always between NIV and high flow nasal cannula, which to use. But obviously, I think there is a place for both HFNC and NIV in managing this pandemic. So the usual question is like when we get a patient in the emergency room with a clear X-ray, and within 24 hours, the patient X-ray is almost getting white out. May not be the case in a COVID, but usually in some ARDS, this is the picture we usually see. So this is always a confusion for us, whether we try an NIV for this patient or do we directly go and intubate the patient. This was an ongoing debate for I think many years in pulmonology and in critical care. And even if you start or if you are going to wait to initiate mechanical ventilation, as you can manage with the HFNC or NIV, how to go about with NIV. There are, as you know, there are many types of interfaces like full face mask, different types of other masks, nasal pillows, helmet, etc., which to use in that situation. He has told you the experience with the helmet, but in India, this is not very commonly used. I think we are also getting the helmet into the practice, but not very common. Even my unit, even now, I don't have an helmet, and I have zero experience in dealing with the helmet as well. So probably I think we'll be getting helmet mask as well in India. So this is the other issue. The mainly we were discussing the self-inflicted lung injury, also called the patient self-inflicted lung injury, PCL. So this is a main concern the patients with the COVID. I will just go through a few slides which Dr. Nava has already explained. So when there is a huge alveolar swing, or when there is a huge alveolar drive or negative intrathoracic pressure is developing, you can see this is a controlled mechanical ventilation, spontaneous and a partial assist ventilation. So in spontaneously and assisted ventilation, there will be a huge tidal volume developing that can again develop lung injury. It can sometimes even favor lung edema and worsening ARDS. So this is a usual pathway, like a patient with an initial lung injury, they will be having capillary leak, they will be having lung edema, impaired gas exchange mechanisms, and increased respiratory drive. So this increased respiratory drive can again produce like an increased the tidal volume, an increased the esophageal pressure swing, or the total pressure swings, and that can again contribute to more lung injury and capillary leak. So this is a usual the scenario we always see, and the patient may generate high tidal volumes which are not recognized in NIV usually. That is the one issue what we always face when we try to manage NIRDS with an NIV. And PEEP levels are usually low, and lung injury may worsen under these conditions, and patients on NIV with high respiratory drive are prone for this PCL. Okay, so we will in the coming slide we will try to see how we can like overcome that. So coming to the NIV in ARDS, especially in lung safe study in 3 different groups, especially when the PF ratio is less than 150, obviously this NIV seems to be associated with higher ICU mortality when the PF ratio is less than 150. So even if you are using an NIV, like it will be very difficult to consider NIV with the patients with the severe hypoxemia or a PF ratio less than 150. So this is the usual way we proceed. Like when you have a highly suspected or confirmed COVID patient, we have to see their age, their other other hematological parameters, how much oxygen the patient is on, and the CT scan. As he was mentioning, there are 2 types, H and L type, which will come to that later. And obviously, we have to look at other comorbidities and warning signs as well. So if the patient is a high risk patient, obviously we have to do a continuous monitoring. If it is a low risk patient, you need to screen the patient twice every day, or like what nowadays what we are doing is during admission itself, we will give them a kit where there is a finger pulse oximeter by which and a thermometer also. So with which they can monitor the SpO2 continuously and the heart rate as well. So when the patient is having a persistent tachycardia or less oxygen saturation, less than 93 to 94 in room air, so obvious, and again persistent tachypnea. So these group of patients are likely to deteriorate fast, and they may definitely require critical care management. And what are the critical care management we do? Like as we have already mentioned, we can either go for NIV or HFNC, which will come to that later. And obviously restrictive fluid resuscitation. This is a very, very important part. And majority of non-ICU physicians are not well versed with this as well, especially when you have a low blood pressure fall or not taking enough fluid, we tend to overhydrate the patient. So that may be true like when you are treating a septic patient in the initial 24 hours. So we know the fact trial, everything. So having or keeping a negative fluid balance is very, very important when you are managing any ARDS patient or any patient with a hypoxemia or a lung injury. The same way, another thing what you have to learn is the awake prone position. So that is also having a very good role in managing the present COVID pandemic. He has also already explained and expressed his experience in doing that, even when you are not having a CPAP or an NIV. So definitely, we also should try to educate our people, our patients, how to do this self-proning, which I'll explain in the coming slides. And obviously, if the patient is still having lower tidal volume, lower inspiratory pressures, then like you can start these, along with the mechanical ventilation, you can try low tidal volume, low inspiratory pressure, low driving pressure, the prone position for more than 16 hours, negative fluid balance, higher PEEP, ECMO, etc. Regarding the higher PEEP, there is a bit confusion. We will explain that later. So this was the initial protocol everybody was following. This was a protocol by a Society of Critical Care Medicine, and again the same was adapted for the surviving sepsis guidelines as well. So when there is an indication for endotracheal intubation, you should never delay that. But if it is not an urgent indication, then and patient is tolerating supplemental oxygenation, you can closely monitor, and again you should never delay the intubation. That is very, very important. And at this point you can try HFNC, or like if the patient is not having a like an indication for endotracheal intubation, you can try a trial of non-invasive ventilation as well. And sometimes, like when the patient is on NIV, to give a gap in between, you can try a high flow nasal cannula if the patient is hypoxemic, or if you don't have like high flow nasal cannula machines and all, at that point of time you can even try a non-rebreathing mask. This is how usually we place the NIV in management of COVID-19. So obviously regarding the aerosol generation, he has already beautifully explained. So even when you keep the patient on high flow nasal oxygen, there is a huge chance of aerosol generation, which can be very well minimized by putting a mask. So any patient in the ICU, if not intubated, please try to put a surgical triple layer mask, even if the patient is on a normal oxygen. Okay. And regarding just before going into how to modify an NIV circuit, which we have already discussed in part 1. So the same way you have to modify the ambu bag as well, and try to avoid ambu ventilation before intubation. But majority of the time, if the patient is hypoxemic, you may not be able to do that. That's why you should not delay the intubation too much and never go for a crash intubation. Always try to do a planned intubation so that you can avoid too much aerosol generation and complications. So this is how we do, like just after the mask, you can put a viral filter, then you can give an oxygen at this point, or here. Then you have to connect a PEEP valve also to the ambu bag. So because sometimes you may require giving a PEEP. So whenever possible, like if you are like developing your ICU, expanding your ICU, etc., when you are giving the specifications, always look for the reservoir bag, then again the PEEP valve for the ambu bag as well. So this is how you modify the NIV circuit, which we have already told. We have to always use a non-vented mask. If possible, you get a full face mask, then followed by a filter. Then you should have a leak port here. And again, this leak port you should not cover. Oxygen you can cover, connect at this point, or if like it is not possible, or some other machines, you can even connect the oxygen to the machine, the port where you can connect to the oxygen port where you can usually connect the oxygen. So this is how you usually connect the circuit. And again, it is advisable to connect one filter near the machine as well. So you usually connect one the one filter just after the non-vented mask, and one filter near the machine. Okay, this is how you usually connect the NIV circuit. And again, regarding the proning, so how to select the patient. So usually you value the patient with SpO2 FiO2 ratio. So if a patient with a flow of 2 to 10 liters per minute of nasal cannula, or with an FiO2 of 0.3 to 6 if HFNC or NIV for at least 30 minutes, then patients have SpO2 of more than 94%, then you can try the prone positioning. You can monitor for 30 minutes, and depending on that, you can repeat the prone positioning or continue. If the patient is having a decrease in the oxygen saturation, then they are not very suitable, because they may suddenly deteriorate. Or in this situation, you can try to like assist supine as well. So what is the mechanism? I think you all are well aware how the prone position is going to help. It is basically the three mechanisms. The dorsal lung segments will be like in the prone position, they will be getting ventilated more, and there will be an offloading of the lungs from the heart, and again there will be better toileting of the secretion. So because with these three mechanisms, you can have a better recruitment and better oxygenation with prone positioning. So, and again, you should know what is this CAR protocol, or otherwise called COVID awake repositioning proning protocol. Okay. So COVID awake repositioning proning protocol. So initially you can ask the patient to be in the prone position for almost 2 hours, followed by the right lateral recumbent position, then sitting up for 60 to 90 degree, then again left lateral recumbent position, then again back to prone position. So the nice articles are available in the net. So make a protocol in your institution. And if the patients are developing hypoxemia, so in the early phase itself, start advising the CAR protocol or the self-proning protocol for your patients. So the main dilemma, like as Professor Stefano was mentioning, so you have a patient with a severe hypoxemia and a normal compliance. This is not very common with other situations. So in COVID, one group of patients, especially as Gattinoni has already mentioned, one group of patients, especially a patient with a L group, where low elastance and high compliance, you can have a severe hypoxemia in those group of patients as well. So the compliance means, I think you all are very familiar with that. A low compliance indicates a lung is very stiff, and again you will have to give more pressure to expand the lung. And a high compliance indicates that a very distensible, easily distensible lung, where with a minimal pressure itself, lung will expand. So we have a group almost similar to an emphysematous lung, or very easily distensible lung. We call it as a H group, or a low elastance high compliance group. So L here means low elastance only. So it will be high compliance, and so that is an L group. And another group almost similar to like a severe ARDS or a consolidated or a fibrotic lung, where there is a low compliance, we call it as an H group. So we have two types of variants, as you all know very well. So these patients will be severely hypoxemic, but they can be sometimes having a silent hypoxemia. There may be normally breathing, and sometimes they can respond to prone position, respond to nitric oxide, etc. And they can vary from a hypocapnic and normocapnic to hypercapnic. So different groups are there, especially when the drive is very high, they can be hypocapnic. So depending on different groups as well. And different COVID patterns can be one where the severity of infection, host response, physiological reserve, and comorbidities you have to consider. Then in second, you have to see the ventilatory responsiveness to hypoxemia, whether the patient is responding to PEEP or not, how is the compliance. Then the time elapsed since the onset of illness. This is also very important. As you know, the complications, the pulmonary complications are usually developing towards the end of first week of illness. So you have to consider all these the points when you are considering a COVID patient. And this I've already mentioned. Because of shortage of time, I'm not going into the details. We have a L variant and an H variant. In an H variant, we have a high recruitability and high elastance. And in an L variant, we have a low recruitability and low elastance and high compliance. So this group of patients are likely to have a more the more drive, and again the so-called silly. And here you will have to you will have a patient who is having a recruitable lungs. So this is the so-called L type, where you have only a ground glassing and minimal patchy opacities. And these group of patients, you may not require a very high PEEP, but you have, and again, the problem here will be a viral infection. Later on, the patient can have a vasoplegia and severe hypoxemia, maybe because of microthrombi. Then an increased minute ventilation, and in increased minute ventilation, sometimes patient may feel dyspneic, may not feel dyspneic. Obviously, in those group of patients, there will be a decreased PaCO2 or carbon dioxide washout as well. So we have a normal compliance lung with a normocapnia, or a decreased compliant lung will be having a basically maybe a dyspneic patients. So the evolution of the disease, like I actually, as we have already mentioned, so the injury attributable to high stress ventilation and evolution of to COVID pneumonia, depending on the severity. The type L patients may remain unchanging for a period, and then they can improve or worsen. The one which I've showed with almost clear lung fields with a high compliance can either improve or they can also worsen, especially the depth of intrathoracic pressure and the patient self-inflicted lung injury in that group of patients can again produce increased lung edema, increased lung weight, and again into the severe other group. So the patient, even the patient is an L group initially, they can also have the complications and develop other issues. So this is the H group of patients when there were in the CT and X-ray you can have a consolidation, and again these group of patients will respond to PEEP well, and the other group of patients which I was mentioning initially, that one with a normal CT, they may not respond to the PEEP well, and in these group of patients giving a high FiO2 is acceptable. Okay. So now coming to the respiratory treatment, initial one, you try to reverse the hypoxemia. As we have already mentioned, the L group responds very well in that the L group of patients responds to oxygen better. Then we have non-invasive options, which we have already mentioned. Either we can go with a high flow nasal cannula or CPAP machine or an NIV machine. So obviously, when we are running short of NIV, we will have to get CPAP also in those machines. And there may be a huge esophageal pressure swing, which we have already mentioned, and there can be a transition from H to L to H type. And when there is a huge respiratory drive, sometimes a deep sedation, whether there is a role, it's not clear. And again, I've already told about giving PEEP in which group of patients. So the first thing is an abolition of hypoxemic pulmonary, like especially vasoconstriction. So especially when the patient is having a hypoxemia, so there will be the hypoxic pulmonary vasoconstriction, and here this patient will be having a high shunt because of the microthrombi happening here in the vasculature, and again these group of patients also will be hypoxemic. Other group of patients will be having an alveolar flooding. So they are the high elastance group where they respond to PEEP, recruitment maneuver, prone position, etc. This low elastance group also can respond to prone position, but they will not be having much response to the response to PEEP, recruitment, etc. And they can be having a high respiratory rate because of increased metabolic demand, hypoxemia, neurotropism, all those issues. So the ARDS severity, you look at PF ratio, CT scan, etc. And again, we always try to keep the pre-plateau less than 30, a driving pressure less than 15, and you will have to keep a PEEP between 5 to 15. And there are different groups of ARDS as well. I'm not going to the details about all those things. But in a high oxygen toxicity, even though we talk too much about these things, especially when these patients are having these microthrombi and again the perfusion issues, there may be some degree of protection against oxygen toxicity, but we will have to see more data to see whether the patient who has received more oxygen are having the post-COVID complications or the vice versa. We will have to see all those things, but in the practical sense, accepting a high FiO2 is permitted in such a group of patients. So now coming to this transpulmonary pressure swing, like when you push air into the alveoli, sometimes when the patient is when having a huge respiratory drive, because of that spontaneous effort, there will be again a diaphragmatic pull down, and again the alveoli will be too much stretched, which again leading on to more the transpulmonary pressure, and more negative intrathoracic pressure will be generated, which again will lead on to self-inflicting lung injury. Okay, so we have to try to abolish this the pull or the huge drive, huge respiratory drive, and we have to try to prevent that. So how to assess this increased the drive or the increased the pressure swing? So here again, you can either go for a like gastric balloon or other esophageal pressure, all those things. But usually in a pandemic situation, those things are not practical. So when there is a retraction of these respiratory, these accessory muscles, or when this SpO2 is less with more tachypnea and there is a more work of breathing, this likely, and again, especially if you can monitor the tidal volume in an NIV, a huge tidal volume in NIV machine, all those indicates that the patient is going for a self-inflicting lung injury. And when you put this patient on NIV, so you have to reassess the patient at least after 2 hours, see whether the minute ventilation, respiratory rate, all these things are settling. You have to see whether the saturation is dropping, work of breathing, whether it is decreasing, heart rate, respiratory rate, all those things. And again, if the tidal volume is still remaining more than 10 ml per kg, that is again a warning sign. This is another situation which I've already told. When there is a too much negative esophageal swing, there is a huge tidal volume will be, or the huge pressure swing will be there, and there will be self-inflicting lung injury. So high drive and high inspiratory effort, and again a low. So in those situations, especially when there is a huge pressure swing, as I've already shown you, even if you give a 16 the pressure here, there will be a negative pleural pressure of -14, which can again lead on to the total pressure of transpulmonary pressure of 30. So there will be a huge pressure swing, can again produce CILI. So you try to reduce the pressure support so that you can reduce the tidal volume as well. And as I've already told you, in pressure support ventilation also, the more support you give, there will be more ventilator lung injury as well. So you can, on one end you can get a CILI, and another end you can have a ventilator lung injury. But just like CPAP in cardiogenic pulmonary edema, here also by applying like adequate CPAP up to 10-15, you can actually reduce this pressure swing, and obviously can reduce the CILI also in these patients. And again, the BiPAP, or if you increase the IPAP too much, that can again increase this swing and can contribute to the ventilator-induced lung injury, which I've already mentioned. So here the basic aim when you are monitoring is you have to monitor the respiratory rate and the tidal volume, and try to step up on the EPAP, and again try to avoid using more IPAP, and again try to avoid humidifiers, and again open suction, nebulization, etc. This is applicable even for an invasive ventilation, and I've already told you, you will have to use the HME filters, and in an intubated patient, always try to use a closed section, and again be careful when you give an oral care for NIV patients as well. The chance of aerosol generation will be high. We have already mentioned the same thing, like start with low oxygen, then try HFNC or CPAP, then you can try awake prone positioning also. And with these measures, sometimes you may be able to avoid intubation. This is again, we have already discussed this slide already. So I think I've already, whatever Dr. Nava has already told, I just tried to explain you how practically you are doing the things, and he has already mentioned the evidences as well. So thank you so much. And again, we will just go through the questions now. Use of steroid for all category, like again we have the I think Dr. Nava will be a better person to explain that. So Professor Nava, like, can you just explain when you will be using steroid, and what about the evidence of tocilizumab nowadays?
Well, about the use of steroids, we were very confident in using steroids since the beginning, despite the guidelines, the suggestion, because first of all, because the virus is a little bit different from the MERS and the SARS, where it has been shown in vitro that steroids may increase the power of the virus. Well, we started using steroid, especially with a CT scan. I have to say one thing. By default, in our hospital, we start to perform CT scan in every patient with fever and symptoms suggesting COVID-19 infection. So in patient with ground glass opacity, we were by default using steroid. Then even in the other, later on, we decide to use steroid. The New England paper, I think, is well done. Large number of patients. Sicker patient tends to respond much better, because in the New England paper, it has been shown that the patient is not on oxygen, it does not respond. If it is on mechanical ventilation or high flow oxygen, you may improve mortality with steroids. Now, the length, the duration of treatment, the dose, and even up to a certain point, the steroids they use may be prone to criticism. I don't know, but they need to start somewhere and somehow, and the data are convincing. So I do not understand why people are thinking about sophisticating drug costing a lot of money, while steroid costs nothing. And it's the only drug with large randomized control trials showing a real effect. Even antiviral drugs, the combination that may be associated with a sort of better outcome, but randomized control trials are not convincing. There are observational studies, small RCT. Here is a huge RCT, despite it's only one study, and arbitrarily chosen about those and so forth. But at the end of the day, I would say I also trust a lot the NHS system. The British people are very straightforward in doing things. And in this paper, they were not, I would say, influenced by big pharma. So I strongly believe, even by my personal experience, that steroids are good to use.
And Professor, what is your institutional protocol for treating COVID now? Which antiviral, and again, at what point do you initiate steroid? What is the dose, and what are the indications for other like immunomodulatory drugs like IL-6 inhibitors?
Okay, the dose of steroid, first we don't use dexamethasone, we use methylprednisolone. We start depending more or less on the weight, but the protocol is the first 4 days, 20 milligrams 3 times a day, 60 milligrams. That depends how big you are and so forth. And then we decrease, but we discharge patients still on steroid. Usually they go home with 25 milligrams of methylprednisolone, and we check them after 3 or 4 weeks. So this is our protocol. And it depends also on the extension of disease, the weight, but more or less this is the protocol. Concerning the other drugs, we started, myself, hydroxychloroquine. We believe in the hydroxychloroquine, especially in the very early phase. Hydroxychloroquine does not only have the antiviral properties, we, even in patients tested positive, without symptoms, discharged at home from the emergency room, we start in the hospital hydroxychloroquine. Which dose? Well, we usually for 4 days. I went up to 8 days, and also at the beginning we associate also azithromycin. Well, I know that this has been sort of criticized, but according to our register, not only me, all the hospital, we didn't have no single case of QT syndrome, no single case. Well, we are lucky, I don't know, but you know, even about hydroxychloroquine, you know better than I do what were the results of the New England and Lancet study. I mean, they were faked probably. So it is an act of faith, I would say. But my gut feeling is also that hydroxychloroquine may work. I don't know, but we don't have except this, we do not have a specific protocol. Obviously, we use anecdotically tocilizumab. We need anecdotically, we use anecdotically other antiviral drugs. But, you know, this was mainly anecdotically. In sicker patient, you do everything you have. We mainly use tocilizumab, to be honest.
And yeah,
yes.
Sorry to interrupt. Yeah. In which group of patients you discharge on oral thromboprophylactic agents?
Yes, we performed to all the patients the dimer assessment. And, you know, with CT scan, we used to perform in a patient with lower SiO2 total body CT scan, because we also observe mesenteric thrombosis. We observe everything. I mean, because if we only focus yourself on the lung and a pulmonary embolism, this may be misleading, because may got other embolism, like we saw at least more than 5 very bad mesenteric embolism. And then we base on the dimer issue. If I recall well, let me come back 1 second if you have the time. I try to see what was the level of D-dimer that we observe as critical in our Lancet study. No, keep going. I come back later with the data about the dimer.
Okay. A few questions like indications while changing from CPAP to BiPAP. I think we have already explained that. But depending on the tidal volume and again pressure support required, you can decide on that. And cutoff. No, what are the indications to go for invasive ventilation? I've already told a worsening hypoxemia, the patient is becoming drowsy, or again hemodynamic instability, all those things. You should never delay the intubation, which we have clearly mentioned that. Is it a clinical deterioration or poor ABG because of many patients looks better, but PaO2 of 35 to 40? I think both you will have to assess. You will have to see the clinical situation and obviously other ABG parameters also. Suppose like if the patient is having a persistent hypoxemia, but maintaining with high FiO2, I think that is acceptable depending on the patient clinical status.
If I may, I found the level that we found statistically significant for increasing mortality of D-dimer was 1,880 nanogram per ml. That was the cutoff for mortality. That does not mean that we started using anticoagulant therapy only above the level, but just to say that this was the level of D-dimer associated with mortality. If you read the paper, you better understand what I mean, because we divide the patient in 4 different quadrants according to D-dimer and compliance. But this was the threshold for D-dimer alone to increase mortality.
Was there any correlation between D-dimer and the compliance?
Yes, patients with high D-dimer and low compliance were the one with the by far the worst prognosis. Yes, because we have 4 different quadrants. Only D-dimer, only compliance, the combination of the 2. So you may have high D-dimer and high compliance, high D-dimer and low compliance are worst. High D-dimer, and so there is a combination of the 4 we see, but if you have both compartments, the alveoli and the perfusion that are impaired, obviously the mortality rate is increased very, very much.
And Professor, one more advice, not regarding the NIV. Like now in India, we are in the middle of pandemic, as you are well aware. Like I'm in the south part of India, Kerala. We are also getting an outbreak now. So what is your advice for the healthcare workers and doctors attending this program to protect themselves? Like, what are the things like you have already shown the data, like how the people were infected, how the people were protected. So what are your advice on, like, and again, what is your observation? Like, what are the mistakes our healthcare workers are doing and they are getting infected? And again, what are the ways by which, other than PP and all those things, to keep away from the disease? Your advice from your personal experience.
I mean, you in India, you published very recently a paper on JAMA showing that.
I've seen that paper, sir. But I was
before and after using the face.
I read that paper.
It's obvious. I think we had so high mortality and so high infection rate at the beginning because we were not prepared. Basically, we did not even have the DPI, right? We didn't have a protection. We didn't know how to dress up. We need to undergo online and live educational session, how to dress up to better. So it's matter of training. It's matter of having the device. And it's better, and it's matter also of never, I would say, slow down your attention, decrease your attention. I think this is crucial because after 1 week in which you spend like 16 hours in the unit, and at one point in time, your adrenaline is so high that you may think, well, now I'm invincible. But then at the end of the day, maybe you touch some. And then the other issue that I always say to my fellow, we are only concentrate on aerosol generation devices and aerosol generation procedure, but our infectious disease colleagues, they are telling me, 50% of the infection are made by contact. So clean your, wash your hands clearly, but also clean the surface. Try to avoid to put food on the table, especially in the hospital, and then eat the food. I mean, this seems to be stupid, but they are important. So I don't have many recommendations. And then the problem is using this.
Oh.
Even outside. Now people, they how in Italy people were using this. Here. they walk like this, just to be safe when they need to enter in a store. Like when they enter in the store, they put, but then they talk with people in the street. They go to the bar and they drink and they got this one. Now the big fashion is just hanging the mask on your arm. This is what people should avoid. So, and schools in 3 weeks from now, school will reopen. That is another problem. How?
Okay.
Now we bought a lot of roller desk for even for pupils, so they must stay 1 meter from each other. But when you are young kids, it's impossible. So I don't know really. It's tough. But for sure, when we lock down, we have a very severe lockdown. We decrease the number of contaminated people. That lockdown, I tell you, was really tough. Most of the people, they wanted to buy, this is funny, but it's true, they wanted to buy dogs. I have 2 dogs. You know why dogs? Because you were allowed to get out twice a day for 15 minutes if you have a dog. So, I have 2 dogs. I receive a lot of phone calls from my neighbor. Can you borrow me 1 dog? So I can go out. Really, it's not a joke. People were asking for dogs to go out. So it was funny because you said, well, I keep it. You are a doctor, you can go out. When I got stopped like dozens of times when I was driving to the hospital and walking to the hospital because police was very strict. if you are a doctor, they say, well, it's okay. They thank you. It was even pleasant because for the first time, the police thank you. So they were stopping us and said, oh, God, thank you for what you're doing. You are great. And so, okay, thank you. Good. Anyhow.
Yeah, Camel is laughing from there. I think in Egypt, they have a different style of putting mask. Do you have Camel? Or the same way?
No, I believe it is the same way here. No big difference, yes.
Okay.
Thanks a lot, really.
Yeah, it was an excellent session, and we really enjoyed Professor Nava, like sharing your experience, and again the way you were like presenting your experience. Excellent, sir.
Thank you.
Absolutely,
Thank you.
I can only confirm, and
it was a pleasure.
I want to thank both speakers. I want to thank Professor Nava for today, but also Dr. Anoop for the 3 days, 3 long, very interesting sessions, bringing us from, I would say, the basics of NIV, and nowadays, or today, we spoke about a very advanced application of NIV. So thank you, Dr. Anoop. You did a great job in guiding us from being a beginner to the expert view on non-invasive ventilation in the most critical patients. Thank you very much. I also want to thank Kamel and the whole team in Breas, India, for setting this up in such a short-term period. They clearly showed that they're capable of doing these things very quickly, very efficiently, and very professional. So I'm looking forward to more of these webinars from Breas in India. And last but not least, I would like to thank all participants who took many hours of their precious time to attend these webinars and to follow us for 3 days around non-invasive ventilation. Please stay tuned. I'm very sure that Pradeep will organize more of these webinars in the coming months. So thank you, everybody.
Thanks to all of you. It was really a pleasure, as I wrote. Okay, ciao to everyone. And please use the mask safely as not okay? Bye.
Thank you. Thank you. Bye.
Thanks, Professor Nava. Thanks a lot.
Thanks.
Thanks.